Excellent, thank you. Hello, everyone. Welcome again to another excellent Mum Predict Journeys in Parent, Patient and Public Involvement and Engagement webinar. I'm very pleased to say that this evening we have with us my excellent colleague, Charlotte Bevan, who works with me on all sorts of projects, and we kind of balance each other out and keep each other in check and all the rest of it. So I'm really pleased that she is here to talk about her journey and how she got to where she is today. Thank you, Charlotte. Over to you.
Thanks very much, Rachel. And I'm going to share my screen. Let me know if you're not seeing anything. A bit of a trigger alert probably, because this does talk about my own personal experience of loss. So I know that there might be possibly people on this call who've also had personal experiences of loss. So please be aware that this might bring up things for you, and we can always chat after the meeting if it's helpful at all. But I wanted to talk to you today about my own personal journey in public involvement and how it began, how I ended up now being co-lead with Rachel for the Policy Research Unit in Maternal Newborn Health and Care at the University of Oxford, as well as an independent PPI consultant for different research studies. So my history, my personal history is that I began my career in print, radio, and as a TV journalist. So I began that straight after university. And for 6 years, I worked, in fact, for the BBC World Service, living in Southeast Asia in Bangkok. I came back to the UK in 2000, where I was working as a live television producer for a channel called Network of the World, which I mention only because it was a kind of a hybrid and convergence, which was a sort of new innovation in television before YouTube had taken off, before Facebook had taken off. But it was also the kind of incubator for people like Brian Cox worked there. He was one of our presenters there. Some quite well-known kind of figures in the media began their kind of career at Network of the World. And it was there where I became pregnant with my first daughter, and a personal experience that drove me to change my career. So I'm going to talk a bit about that, if that's okay, the long relationship I have with the charity as a result of that personal experience, and my movement into a more sort of general coordinator and lead for public involvement. So that's me with my husband, Jim. And very sadly, we had a little girl, Hope Charlotte Williams, who was born and died that same day on October the 11th in 2001. This was a so-called low-risk pregnancy. I was in and out of labor over about 2 or 3 days, not probably established early labor, but certainly having contractions of some kind or another. And by the time they realized that she was not doing well, I was about 35 weeks pregnant, they called for a crash C-section, and tragically she died very shortly after she was born. I mean, she was essentially born dying, and they tried to resuscitate her unsuccessfully. And they told us that her death was unexplained, but consistent with what we know. And I have to say that for me, as a journalist, was very confusing. You know, I'd worked in journalism 13 years. My job was to find out the answers to things. And so I had a lot of questions about why could something be both unexplained and consistent with what we know? So if it's unexplained, why is no one doing anything to try to understand why it happened? So she was perfectly normal, normally formed, no congenital anomalies. There was nothing kind of untoward. I was just told that it was a tragic and so-called unavoidable event. If you lose a baby in the NHS around the time of birth, you are automatically referred to a charity, certainly in England, in the vast majority of units in England, to a charity called SANS, a stillbirth and neonatal death charity. You may be familiar with it. It was founded in 1978 by Belle Mooney, who's a writer, journalist, and broadcaster. She was married to one of the Dimbleby brothers when she lost her little boy, Tom. That's a picture of her there with another son. And it was co-founded with another lady called Hazel Ann Lewis, who was a psychiatric social worker whose baby had died neonatally. So Tom had been stillborn, and Hazel Ann's baby had died as a newborn. And they both founded this charity because they felt that their loss was completely unacknowledged by, not just, I think, to a degree, not just by the system, by the NHS itself, but also by friends and family who really struggled to sort of support them through their grief. And actually, if you get a chance to read this article that she wrote in The Guardian at the time, it's an incredibly powerful piece that explains the impact of the loss of a baby around the time of birth, when people really struggle to know what to say to you, because it's not a child that's had a life that they have connection with, that you can share memories with about. So I went to SANS peer-to-peer support groups in the sort of early weeks after Hope's loss. I ordered a post-mortem for her, which was inconclusive. As I said, it just said that her death was unexplained. And I was living in London at the time. I went to one of SANS's peer-to-peer support groups in somebody's sitting room, and I was kind of astounded to discover, because of course stillbirth and neonatal death was really not something I had thought remotely about. I knew that I might miscarry my baby at some point in the first 12 weeks or 24 weeks of pregnancy, but not that I would lose her at the later stages of pregnancy. And what surprised me at SANS was there didn't appear to be any prevention agenda at the charity, or any sort of collective agreement that deaths could be prevented in any way. So for me, there was this huge question mark. Everyone was supporting each other in terms of bereavement, but nobody was actually addressing the question, do these babies have to die? Do we need to be supporting so many bereaved families? So I started working at SANS because I had this background in journalism. I didn't want to go back to work at Network of the World in journalism. I couldn't really think of doing anything that didn't really resonate with my own personal experience. I couldn't really sort of write about, I don't know. In fact, the channel that I was helping produce was the Film and Arts channel. It was all very interesting, but for me, the most pressing thing was trying to understand this issue. And I started working there in an ad hoc way, sort of editing their newsletter and things like that. But eventually, I started working with a colleague to really establish a research and prevention agenda. And we did this by essentially networking with researchers like Peter Brocklehurst, who was running the National Perinatal Epidemiology Unit at the time, who Rachel's also very familiar with, and who's a leading researcher in perinatal research, understanding women and perinatal health. Gordon Smith at Cambridge was another very important ally at that time. And so was Alex Heasel, who ran the Tommy's research unit up in Manchester. But not all the doors were open. And I have to say the Department of Health was one of them. We had a sort of memorable meeting, me and a colleague at the Department of Health, where they kind of, we had about an hour with, I think it was called the Starting Well Department at the time, where civil servants I think sort of felt that we were just another kind of problematic issue in maternity. And you were definitely at that time, I'm talking kind of, by this time it was more like 2007, 2008, there was a feeling that we were a kind of fringe group of sort of sad people, but there was nothing that you could particularly do about it. So, coming from a journalistic background, I worked with colleagues to write this report. And at the time, it felt very brave calling it the Saving Babies' Lives report, because, as I said, people weren't thinking in terms of prevention. And in a way, this is where the sort of public involvement and the parent voice really starts to sort of ring true in this particular and difficult and challenging area, which is that if you actually connect people to people's personal experiences, it brings the issue much more alive. So we dared to call it Saving Babies' Lives, and we dared to put a picture of a couple on the front of it with their dead baby. So that little girl is, she had already died when that, shortly after that picture was taken. And we called it, we launched that report in all 4 nations of the UK. with a campaign, alongside a campaign called Y17. And it was called Y17 because 17 babies died every day in the UK at that time in 2009. And we named 17 babies on every chapter of that report. And we called for a strategy to reduce the deaths. And I think it was the kind of naming of those babies and the pictures of those families that really did ring true for policymakers, researchers, anybody who was interested in working in the maternity space at that time. And then we dared, a few years later, to write a report called Preventing Babies' Deaths. So this was launched in 2012, again, written by me and a colleague. And we really wrote these reports sort of in consultation with researchers and policymakers who were supportive of the work that we were doing and the calls we were asking for, this roadmap to change. But to a degree, we cited research, but we had a parent survey of our own that we'd done in 2008. But there wasn't that much research around, particularly around stillbirth, unexplained stillbirth prevention. There wasn't. But we sensed with the people that we'd spoken to, the research that we'd looked at, and a sort of hiatus in the audit program for collecting data on perinatal deaths at the time, that there were several things that we could in all clarity ask for, and that was the fact that there was no standardized review process for understanding why babies died. It was done in a very ad hoc way across the country, and parents were really suffering as a result of how ad hoc this was. And in most cases, parents didn't even know that any review might or could take place. Because there was no audit program, there was no sense of who was at risk. And also there was no prioritization of research. I mean, everybody calls their areas of research the Cinderellas of research, but this was really universally this area around understanding what happens in those last stages of pregnancy and why some babies do die. There are these antepartum stillbirths late in pregnancy for no particular reason. I think at the time 1 in 3 stillbirths was unexplained. So we were calling for money and funding and sort of people to come together and decide what research should be prioritized. And we wanted to improve professional awareness because I would stand in queues at conferences where I'd overhear midwives, or midwives would say to me, you can't prevent a stillbirth. That was the current thinking at the time. And also we wanted to improve public information around your health in pregnancy, particularly around things like reduced fetal movements, because these were things that parents were bringing up when we spoke to them and in the surveys that we were doing. And we illustrated that report with, again, so that first report, we had the 17 names of the babies who had died. This report, we wanted to show that what you're dealing with here is this profound experience in a family's life where 1 minute a mum is heavily pregnant, expecting a new baby, a new family member, preparing a cot, preparing a room, having her antenatal classes. And in the next moment, she is facing, and her partner are facing, the family is facing the worst experience of their life, something they literally do not anticipate. And that point, which of course I had personally been through, acts as a kind of watershed. I mean, most people that we were consulting with, most parents and families we were consulting with, would describe this as devastating and isolating. And Michelle Hemington actually went on to found something called the Campaign for Safer Births because her son Louis actually died during labor, and she felt that he was born alive, and she was told that he died during labor and was born dead. And she began. You can Google her and the work that she's done. Some very sort of powerful work she's done around raising awareness of intrapartum related deaths. So we'd done this survey, as I said, of parents' experiences, and we had, as a result of it, we had lots of qualitative data that we didn't really know what to do with because we didn't have the expertise. We weren't researchers. When SANS was founded by Balmuni in 1978, and it grew, but it grew among a very sort of, if you like, in a way, a bit of a niche group of bereaved parents. It was a kind of charity run by bereaved parents for bereaved parents. We didn't really have anybody with research expertise. So we had this report full of information, but we hadn't included the qualitative data in it. Just just the odd quote. And we were already sitting on the policy research unit for maternal and neonatal health and care at Oxford. So SANS was already a representative on the PRU. And they, as you may well know, they run a maternity survey every 4 years in England, looking at women's experiences of maternity care in the NHS. But they never, of course, canvass the views and experiences of families who are bereaved. So I went to the PRU, to Maggie Redshaw, who works at the PRU as a quality researcher, and I said, it feels like an iniquity to me. We really need to know if we're going to improve maternity safety. I know this is at the time it was around 5,000 families were losing a baby around the time of birth every year in the UK. And we need to know how they feel about their experiences in order to sort of push this issue up the policy agenda. So rather than, I literally turned up at Oxford with sort of virtually piles of paper because we printed off the survey. It was kind of, 2009. We had done it via a marketing company, I think. So nothing was being sort of shared, in the kind of quick, speedy, sort of digitally technical way that it is now. And Maggie said, look, we're not going to look at your data. We're going to start again. And so I worked with them as SANS representative, and we created the first national survey of bereaved parents that was ever undertaken in the UK. It was focusing really actually mostly on families in England. And it was commissioned by the Policy Research Unit, but as part of, if essentially the taxpayer paid for it, it was considered an important piece of work. And we very much supported the PRU in creating this survey, in making it possible to get ethics, producing all the kind of wraparound information for parents to make them feel supported in contributing. And they heard from around 700 different parents and summarized everything in this report that you can still download. So it didn't come out as a peer-reviewed paper, it came out as an online report. So just sort of tracking back a bit, because in all this, of course, I was working as a SANS, I was working as a SANS employee in their we called ourselves the Research and Prevention Department, but what we were trying to deliver was all the things that we'd asked for in those previous reports, but particularly the preventing babies' deaths, where, as I said, we had this roadmap for what we thought needed to happen. And I suppose throughout this, I was putting not my personal lived experience, but the lived experiences of people families that we were speaking to, families that we knew about. And, I'm happy to say that as a result of that report and the engagement that we got as a result of it, we did get standardized review. The government commissioned in 2018, it was rolled out, something called the Perinatal Mortality Review Tool. So it's a standardized review tool. And that came about after 5 years of collaborative working with all the royal colleges, with various key stakeholders, with representatives from Scotland, Wales, and Northern Ireland as well, because we wanted it to be UK-wide. And the idea is that, whenever your baby died, if a baby died after 22 weeks gestation, right up to 4 weeks of life, and of course it does actually also include infant deaths, but those are slightly more complex in terms of review processes, that every family should expect a standardized review. And it abbreviates to the PMRT. And I was the SANS representative on the PMRT collaboration. So if you can imagine, I was almost the only non-professor in the room. So I was the only family representative in the room. We'd meet once a month. We'd talk about how the program was going to work, how the tool should be developed, how we were going to capture parents' views of their care. That was incredibly important. And at one stage, there was so much work going on with the PMRT. I had to really sort of say, look, we've got to fast track this parent engagement pathway, because unless there's a pathway for engaging parents, then how do we know that healthcare professionals are doing it in a meaningful way? So that was rolled out in 2019, but I led a subgroup of other family representative organisations, charities, as well as members of the PMRT. And interestingly, 2 or 3 of the clinicians on the PMRT are themselves bereaved parents. They have experienced loss themselves. So it wasn't that I needed buy-in at all. And we developed that parent pathway. It was rolled out, and it's now being used. And I think it might be going through another iteration now. And then we developed training for healthcare professionals in using the parent engagement pathway. And I did that with SANS. And again, using parents' voices at the heart of that training, so that people on the training could hear what it was like for a parent if they didn't get a robust review after their baby died. And the truth is that a lot of parents experience really long-term harm from not getting answers about what happened to their baby. And for those who feel that something could have been done to prevent the death, that can cause what we used to describe when I was working at SANS as compounded long-term harm. It's really it has I would say a kind of cross-generational, transgenerational effect on families when they feel the NHS hasn't been open and honest with them, and if something has gone wrong. So as a result of that, I have also became involved when I was still working at SANS as a PPI representative on other related studies, and the one in particular that's going to be really interesting. It's sadly not published yet, but it's called Discern. It's open disclosure when things go wrong in NHS maternity, and it's a really interesting what's called it's basically a kind of a review that looks at the grey literature as well as the peer-reviewed literature, and does lots of qualitative analysis of both healthcare professionals' experience of open disclosure as well as families themselves. I think it's called a realistic review. A realistic analysis. And then the other thing was that we didn't have any data. So another thing that came out of the collective call for the hiatus to be stopped in the audit program around perinatal and maternal deaths was the emergence of the Embrace UK collaboration in 2013. So they collect data on all the risk factors for every mum and baby related to age, gestation, ethnicity, poverty, condition, and they're a really powerful and I think effective, very professional organization. And again, I was the SANS representative on that collaboration. So again, meeting once a month with people who were far more academically skilled than I was, and who'd been had a long history of working in epidemiology and things like that. So I had to sort of sit in these quite complex meetings and think, where can I put the parent's voice? At what point can I put up my hand and say, hold on, you've forgotten the parent in all of this? As part of that work, so what happens with Embrace is they collect all the data on mothers and babies who die across the country, because they're looking at risks, they're looking at where units have higher rates than other units and trying to understand why that pattern exists. But to get into the real sort of detail of the kind of care people are experiencing, families are experiencing, they do confidential inquiries. So confidential inquiries, just in case you don't know, sorry, and apologies if you do, but when you look at a series, you choose a topic and you look at the case notes. So you look at the medical notes associated with the care for somebody who qualifies for that confidential inquiry topic. And they run these for perinatal deaths every other year. Embrace does it every other year. So for maternal deaths, they do it every year to cover all the different reasons why mothers die. But in perinatal, and I would say there's a stark inequality there, but in perinatal care, it's partly to do with the funding. They only do it every other year. And it's a competitive process. You have to, it's an open call. People submit ideas for topics for confidential inquiry. And whichever one, there's an oversight group, DH agree it, Department of Health agree what topic is going to be addressed next. And I wrote the proposal for the confidential inquiry into antepartum stillbirths. And I think that was run in 2015. And what's so profound about it is its finding, which was that 6 in 10 of those antepartum stillbirths at term, so after 37 weeks, they found that when they reviewed the care in this multidisciplinary panel of people entirely not involved in the care, they were confidential, so all the notes were anonymized. They found that 60% of them were potentially avoidable. And we also called for a confidential inquiry on antepartum related deaths, which also I was involved in writing, although we weren't the only charity calling for that at the time, that found that 80%, 8 in 10 of any intrapartum related deaths at term that were reviewed. So they take a whole bunch of case notes, and once they reach a kind of saturation of themes that emerge from those case notes, they then stop the inquiry, but they found that 80% of them were potentially avoidable. And actually they employed me in Brace as a freelancer to kind of coordinate and write the lay versions of those reports so that we could really hit home with those messages. And the way that writing works is that, because it sounds a bit sort of that like there'd be a conflict of interest there, but actually what happened was I was literally just the sort of person putting the words together. And we had a panel of people who were interested in these topics from third sector organizations, who would say so they'd look at the whole report, the whole confidential inquiry report, and they'd say, look, these are the messages you need to focus on, that we really need to ram home for this piece of work. So we come I hope I'm conveying that we come from a place where people were saying, you can't prevent the death of a baby, to a place where, since those inquiries, term baby deaths have fallen by 30%. So it was really, truly a profound change in the whole narrative, but also in the genuine saving of lives. So another thing, as I said, with regards to the the research, being seen as the kind of Cinderella of research, perinatal health, and of course, research in pregnancy is always very tricky, and there are lots of different views about how pregnancies should be managed and births should be managed and delivered. But we did at SANS start a clinical studies group around stillbirth, because stillbirth was still that kind of taboo subject where I mean, it was, people were kind of they were more accepting of the idea that you could prevent the death of a newborn baby, because of course you've got somebody you can see, you can put them in an incubator, you can measure their temperature. Whereas the kind of antepartum stillbirth, where babies, there was a kind of black box of pregnancy, there was a less instant recognition that you could save those deaths. So we had these, I mean, that's me and my colleague Janet, who's to the left of the president of the RCOG at the time, the Royal College of Obstetricians and Gynecologists at the time. So she's on the left of him, I'm on the right. And he's in the middle there. And that was the Each Baby Counts launch. And I don't know whether you remember Each Baby Counts, but that again was about the paucity of reviews, this bad system of reviewing that was going on when babies died. And the lack of robustness, the lack of lesson learning, the lack of admission that things were going wrong in maternity care. So we launched this clinical studies group, and basically what it was a group of individuals, researchers who had a specific interest in this area and who incubated ideas for research. And now SANS, I mean, it's involved in, not directly funding, but involved in up to 100 different research studies into preventing baby deaths. And then there was this issue around raising professional awareness, and we were involved, and I sat on the very early discussions at NHS England's discussions around the Saving Babies' Lives care bundle, which is essentially just, I mean, in many ways, it's just routine care that already has guidance associated with it. But the idea of a care bundle is that if you put all these things together and you check that you're ticking all these boxes, then you are likely to have some impact on perinatal health and the outcomes for mums and babies. So it began in 2014, so it's like 10 years now, and it's now in its third version, the Saving Babies' Lives care bundle. It's just in England, but it's about identifying support for women who smoke in pregnancy, identifying babies who are small, so standardizing the way we look at fetal growth and having interventions if we're worried about the baby, raising awareness of reduced fetal movements, because again, this was coming up time and time again for women who had lost their baby. I mean, I think in the sort of listing, we called it the Listening to Parents survey report, the one that the NPEU did, the first national survey of bereaved parents' experiences of care, because so many parents said, we felt like we weren't listened to. We felt like we weren't listened to. And of course, this is kind of, we hear this time and time again for women who leave maternity units with live babies. But the sort of tragedy, of course, feeling not listened to when your baby's actually died is really difficult for parents, because of course they carry so much guilt about the fact that they didn't manage to shout loud enough, and I certainly did myself. Effective fetal monitoring with CTGs, getting that right, reducing preterm birth and managing management of pre-existing diabetes. So that's all in the latest care bundle. And then, I mean, as I said, we always try to put real voices at the heart of everything we did at SANS, and they still do. I'm not working there anymore, but I certainly think the power of a family's voice is, there's no kind of measuring it. And it's interesting because Lisa Cooper, so she had her son Archie died in 2009, and she had lots of she had high BMI. I think it may have been an IVF pregnancy. I cannot remember, but I do remember the family, her husband Lisa and Glenn, coming to SANS and saying, what about, why does nobody understand? Why did we never know this could happen? And I'm not too sure they were able to go on and have another baby because they were older parents. And she said, as a pregnant woman, how can I contribute to the management of my own care if I don't know the risks? Because when she went back to her midwife after Archie had died and said, why don't you tell women about the risks of stillbirth? The midwife said to her, because it's scary, and we don't feel like we're in a position to share that kind of information. We'll just tell you about the risks, but not about the worst outcome that could possibly happen. So SANS we created, I spent a lot of time working with a multidisciplinary group again, but lots of third sector stakeholders, including Bounty, actually. So sort of commercial aspect to it as well. Department of Health is really keen. I work with them to produce a series of safer pregnancy messages, and what came out of it was a website that SANS effectively hosts, but it's just sort of it's described as kind of no nonsense, straight talking advice about things to look out in pregnancy. We don't particularly use the word stillbirth because we developed the website and the information we have it partly through focus groups with families who had either been pregnant or were pregnant and who had no knowledge of stillbirth and never experienced stillbirth and had no sort of particular extensive knowledge of stillbirth. That's how we recruited them across England. Actually, it might have been UK wide, but we came out with a series of messages we thought would be helpful for women, and it's signposted to from the Saving Babies' Lives care bundle that I've just been talking about. So, I mean, as a result of kind of all this work, there was essentially a massive policy shift. So from that day when I went with a colleague into the Department of Health to see the civil servants who kind of looked as if they were way too busy to address the issue, and there were lots of other priorities in maternity, and the 5,000 babies who die every year around the time of birth were just a tragedy that couldn't be avoided. There then became a different narrative. And, this discussion around particularly these term and intrapartum related deaths. I mean, when you did the maths of the 8 in 10 potentially avoidable, you were talking about hundreds of babies' lives every year. And Grazia magazine picked up on this, and the Sunday Times picked up on this, and they said, we need to stop the stillbirth scandal. And that is the petition that the chief executive of SANS, that's with Anne Milburn, who was she was working in I think she was possibly in opposition at the time in health, with a couple of colleagues on the right there. And that was a petition that we took to number 10. And as a result of that, the policy shift has been, really profound, because Kath Calderwood actually was running NHS England at the time. She subsequently became, she was running maternity for NHS England at the time. She subsequently became chief medical officer in Scotland. But in 2012, Scotland did actually set a target to reduce deaths by 15% by 2015, and they set up their own stillbirth working group. And while it was quite focused on stillbirth, everybody really knew that if you were going to stop stillbirth, you were going to, or at least, reduce stillbirths, you were going to have an impact on neonatal deaths, because a lot of babies who were dying neonatally were dying because of something that happened in the antepartum period. So they were born sick, or they were born too soon, and it had impacted their well-being in those early hours and days of life. And then Jeremy Hunt, who was then Secretary of State, set an ambition to reduce baby deaths by 25%. He did that in 2015, by 2025, and by 50% in 2030. And so when you look at the statistics now, and I'll show you them a bit later, they are, we have seen a real shift. I mean, I won't talk too much longer because I'm going to use up all the space talking about this pressing issue. And I guess it's, essentially what happened, I guess, in terms of my journey in public involvement is that, we had to wait until we got all the bad news because it wasn't until we amplified parents' voices and we brought the researchers and the policymakers together that these types of reports started coming out. So the Lancet Still series that said that still the birth rate in the UK was one of Europe's highest. They produced another report in 2016. And then, of course, we've had lots of, distressing reports, frankly, into safety and maternity, including Bill Kirkup's Reading the Signals into East Kent in 2022, but there are a few others of those. But we saw, as I said, that the landscape changed from being 17 babies dying every day to 13 babies dying every day today. And this move from stillbirth being a taboo to the death of the baby being recognized as a universal tragedy, not just for individual parents, but for society, I think, as a whole. So it's, I mean, these are just very small handful of the organizations and universities and projects that I have worked on in my time at SANS. I mean, it's been a really interesting journey for me personally. I had to present at lots of international conferences. I had to be that lone voice of the parent. It was at times very challenging. I put asterisks next to those places where I spoke internationally. And I think a lot of people abroad sort of were really impressed, I think, by how SANS had harnessed the parent voice and was using it for policy change. And then I had to do, obviously, lots of stuff, in the media representing SANS, and that was all quite interesting and challenging. I prefer to be the journalist asking the questions as opposed to the person on the other side of the microphone having to answer them. But that all brought me eventually to work with Rachel on the Policy Research Unit as her co-lead for the public involvement there, which I've been doing since 2019, because in fact I became pregnant again after I lost hope with a little girl who's now 21 called Phoebe. And so I worked part-time. I had a lot of, challenges in having another baby after Phoebe. I had miscarriages. I had developed something very rare called Asham's syndrome as a result of a miscarriage. That meant I had to have lots of IVF because by then I was in my late 30s, and we decided to go for some IVF, which was unsuccessful. So I never really wanted to work full time. And so I sort of dovetailed my SANS work with the PRU work, and we design and support the delivery of the PRU's PPI strategy. And one of the projects we've worked on together is the listening series, which we're really sort of proud of, Rachel and I, which is, getting marginalized voices into the research space to ensure that they are heard. And do look at that because it's a great piece of work. We think I think improved some of the work that we do at the PRU in improving diversity and inclusion. And these are some of the things that people said about if you want to hear from us, you need to build trust, involve us from the beginning, show us how you're going to impact the lives of the people that we care about, our communities, use communications that are appropriate for us. If if there are physical disabilities, address those in terms of your communications, or if there's special educational needs, address those too, and imagine what life is like for us before you start asking us to hear from us. So I think, like Rachel, I guess that this journey has helped me develop an expertise in delivering PPI strategies for research, making sure that all voices are heard. And I'm involved in these other studies, Oxford Labour Monitoring Group with Rachel as well, the MATREP study, which is something I do with somebody called KG Moses, who's a very powerful voice. Another bereaved parent, we co-lead the PPI for that, and there are lots of other studies in the pipeline. And essentially, what we're all trying to do is ensure that applications for funding address the public involvement issue meaningfully, both in making sure all the right voices in the room and paying for them, and making sure that there's a strategy in place right from the beginning to hear from people. So, of course, I wouldn't be here if it wasn't for Hope. That is her grave. If she had lived, she'd be 23 now. So I'm very sort of conscious that this journey that I've been on has is shaped entirely by her. It changed my life, essentially. It's hard to imagine, you can't, when your life has been changed so profoundly, it's hard to imagine how it would have been different. And I suppose some of the things that I have developed, the skills that I have developed is in my journey to public involvement, is the need to overcome fear, because I'm often sitting in rooms with people who are got titles, or who are powerful because they are politicians or they are civil servants. I've had to develop even greater public speaking skills than the ones I developed working for the BBC. I've had to understand the levers of influence. That's another picture of Peter Brocklehurst, but he's a very respected researcher, and working with him really did shape the work that we did and our engagement, because people took him so seriously and the research he did so seriously. Using the power of the lived experience, I mean, there's just literally nothing like it. That's Bell Mooney again. Engaging people constructively and not being negative. We tried at SANS, and I try as well in the work I do now, to be constantly constructive and collaborative and not adversarial, and not give up, because it's very tempting to when another terrible report comes out or another group you realize has not been included in the conversation, it's very tempting just to say, I'm 20 years into this and we are still hearing negative stuff, and that's depressing. So I actually resigned from SANS in January this year after 17 years of working there. And as you can see, my husband has now lost all his hair. And I would say that essentially, that's Phoebe, my lovely other daughter, who's 21. That's her a couple of years ago, though, actually. But I would say, it's not without personal the personal burden. I would say there were times in my journey of public involvement, my journey of working with SANS, when my husband Jim found it difficult. And I was so used to having having various reports open, like with words like preventing babies' deaths and saving babies' lives, that I kind of would not notice that I'd left them on the kitchen table, and he definitely found it very challenging. So it's not without a personal cost, I think, but I wouldn't not want to have done it, and because to a degree it was, and being this person and making sure that not just by sharing my experience, but by sharing other people's experiences, because that for me was the most important thing. I was just a kind of conduit for other people to share their experience, that I was somehow making a legacy for her, a legacy for hope, and making a kind of giving meaning to what was essentially a completely sort of meaningless and tragic, event for us as a family. So thank you for listening. I am sorry, Rachel, to have definitely gone over time. And any questions that I can address, please feel free to ask.
Thank you ever so much, Charlotte. That was both interesting and personal and incredibly informative. So thank you so much for that. So I'm going to stop recording now.